This podcast episode is brought to you by Creative Safety Supply, leaders in visual safety, floor marking, label printing, and more. Visit their website at www.creativesafetysupply.com/leanpodcast for a special 10% listener discount.
Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 154 of the podcast for July 31st, 2012. My guest today is Rick Morrow. He is a director at the consulting firm Healthcare Performance Partners, and he's author of the book titled Utilizing the 3 M's of Process Improvement in Healthcare, a roadmap to high reliability using Lean, Six Sigma, and Change Leadership. And that book is from Productivity Press, which is also the publisher of my books. So in the episode today, we're going to talk about his book and his experiences with quality in healthcare, as well as something that's really a favorite issue of mine in terms of a soapbox issue and something I get fired up about, the idea that we shouldn't ask patients to inspect the work of healthcare providers, that's an unfair position to put them in. So we'll talk about that and a lot more. For the episode's post page, you can go to leanblog.org/154 if you want to leave a comment. And you can go to leanpodcast.org for all past episodes. Well, again, our guest today is Rick Morrow. Thanks for joining us on the podcast.
Thank you, Mark. It's my pleasure for sure.
So if you can start off just basically introducing yourself to the listeners. I'm curious to hear about your background with healthcare quality and Lean.
Thanks, Mark. Sure. I am a guy that has failed quite a few times. So my mission in life is to give back and prevent people from failing the way I failed. So that's the big reason why I wrote the book, Utilizing the 3 M's, is to share where I kind of goofed up over my 30 years in high reliability organizations and hopefully give some people some step-by-step tips on how to lead some major changes in healthcare quality, safety, and reliability, as well as most any industry.
And you're currently with Healthcare Performance Partners. Before that, you were with the Joint Commission. Have you been in healthcare your whole career?
No, I joined healthcare about 6 years ago, and Dr. Mark Chasson of the Joint Commission and his staff called me one day and said, "We'd like you to come and talk to us at the Joint Commission." And I asked my wife, who's a nurse, I said, "Jan, who's the Joint Commission?" And she kind of laughed. She goes, "Why?" And after talking with a number of people, including my family physician, I got a couple questions about why would you interview there. But I drove over, it wasn't too far from my home, and I met Lynn Dragosick, the VP of HR, and she started out on the mission of where Dr. Chasson wants to take the Joint Commission. And I was intrigued, and Mark just happened to have some time that day as well, and we sat and we talked about his vision of not making accreditation the sole mission, but to actually go out and collaborate with some of the world's leading institutions in healthcare and solving some of their toughest problems. And I just fell in love with that vision of his and the mission. And so that's when I really got involved with healthcare.
And so then writing the book, utilizing the 3 M's of process improvement in healthcare. And we'll have a chance to delve into what those 3 M's are. But always curious to hear, even just from an author's perspective, what inspired you, what motivated you, what was the story behind the book and how it came to be?
When you get to be my age, in 30 years and a lot of experiences across the world, it's time to give back, Mark. It may sound corny, but it truly was my attempt of giving back for all the great experiences I've had with companies like Motorola and United Airlines and Eaton Corporation, but also since healthcare especially is such a fragmented industry. There's no one Toyota or no one Boeing corporation that can look at its thousands of suppliers and say, "Oh, this supplier over in Kentucky is doing a wonderful job. Suppliers, we think you all ought to try this." Or like in the automotive industry, you're familiar with their design right the first time, whether you call it PPAP or APQP, some acronyms that I don't even know what they are anymore, but the infrastructure built in by these major oligopolies that then can share best practices across it. There's no oligopoly in healthcare that I know of that can take a number of great ideas and then distill it for people and then teach people how to do it and share it. So hopefully the book takes a little bit of a direction toward that, of being able to take some really good practices and share them with the rest of the world.
No, it's funny. Yeah, you're right about healthcare in the United States being so decentralized and not being any major player. What I'm curious, before we come back to the book, how you see the influence then of, let's say, the federal government is a big payer through Medicare, Medicaid. You're coming to us live right now from England, where it's a much more centralized model with the NHS. I mean, what are some thoughts you have about whether that sort of central drive to say "thou shalt improve" has potential, or if you see impact with that?
That's an intriguing question, and I appreciate this opportunity of comparing a little bit about the very centralized NHS. But even the NHS is a number of trusts, which I didn't really realize, and they act fairly independently as well.
Yeah.
But there is a lot more centralization, as you know, here. There is better sharing of best practices in the NHS, so I think it does approximate some of the more oligopoly type environments that we have in other industries. One of the most intriguing things that I find is they have the same problems in the UK as we do in most hospitals across the US. Things like, how do we really get people to be mindful in some of these situations, whether it be for surgical services? How do we even get people to wash their hands? And we knew back 1846, Dr. Semmelweis proved with data, much like we in lean healthcare, we love to make our case with data versus just anecdotes. How do we all have the same problems, and yet why do we keep reinventing the wheel at each little hospital or each little organization? The NHS does have it, and thankfully, even with our Centers for Medicare and Medicaid, they're doing a better job these days, I feel, with their value-based purchasing, of at least taking the hundreds of process of care measures, outcome measures, patient sat measures, but distilling those down to fewer to help people focus. And that's what I see really positive going on in America right now, is letting people focus on the vital few.
And you bring up the important concept of measurement. So let's transition a bit. There's a lot to chew on, even in the title of your book, the 3Ms, if you can kind of give the listeners introduction into what the 3Ms are and why that framework is important.
Yes, when I look at great leaders, whether it's Abraham Lincoln, some of the great presidents of the U.S., and we even look across the world, Winston Churchill, what did these people have in common? And the one thing is they all measured. And we all know the old saying, if you want it, measure it. And you can't really change behavior unless you have some way of measuring the behavior. So what I've found in every successful change has been the ability of having that scorecard. Think of it as, here we were literally looking down on the Lord's cricket grounds today, watching the archery practice. So the archery Olympic events will be just literally across the street from the hospital here. And you could see the scoreboard. So imagine here in healthcare, like in the ICU, you see an excellent example of a real-time scoreboard. It's called telemetry. We can see the blood pressure, the heart rate. But yet, how many times do you walk the med-surg floor or even in surgery, and there is not one measure posted at all?
Yeah.
But yet Abraham Lincoln would walk literally down to the telegraph office, and he would go to the telegraph to see what was the measure of the prior day, what was happening that day. So the great leaders had a real-time measurement system. So that's the first M. If you want it, measure it. And so often we don't measure in healthcare, but yet we have some great examples like the ICU. But putting a chart up on the wall or putting a scoreboard up, think of in baseball, you've got the pitch count for pitchers. What if the pitching coach or manager never looked at that? Mm-hmm. You could have the greatest measures, but if you don't manage to that measure, so that's the second M. So measure is the first M, and then manage to the measure. If you don't do something with that measure, it's worse than measuring at all, because now you've had people go through the exercise of measurement and you don't do anything with it. So Abraham Lincoln didn't measure what was going on, what he saw through the telegraph, without managing to it. And he is known, that I found through the research for the book, that he swapped a lot of generals out. He kept measuring, and then he had to keep managing to that measure. And one of his management practices was to keep looking for the generals that could move the army, the nation forward and where he wanted to go. So that's the second M, manage to the measure. And then the third thing, and hand hygiene is probably the most voluminous example here, is we can measure hand hygiene. And oh, by the way, the monthly or quarterly hand hygiene statistics we've proved over and over is worthless. You have to measure in real time or near real time. And then you have to manage to the measure. So the other day, we launched hand hygiene at a major academic medical center, and I could not be happier with the nurse manager and the nurse director. They were measuring daily through trained observation, and I walked out one day expecting to have to argue about, well, now you have to do something about it. But here they'd already brought over a group that healthcare workers that had the lower compliance on hand hygiene than other workers. And on their own, before I ever showed up, they had already pulled them aside and they started the problem-solving methodology of saying, you know, you're lower according to our data. What's making it difficult for you to wash your hands? And so the third M is you got to make it easier to do the right thing. And we know it in lean healthcare as far as standard work, job instructions. So wrapping it up, the three M's are simply you have to measure, you have to manage to that measure, and you have to make it easier to do the right thing.
Well, and I think, that third point, tying it back to making it easier and asking why and identifying barriers to those problems is what leads to real improvement. Because when I hear the phrase manage to the measure, sometimes I think, oh no, this is like teaching to the test, or that if we, in the absence of an ability and a willingness to make the work easier, a measure sometimes can pressure people into fudging the numbers or doing things that are dysfunctional instead of driving real improvement.
Absolutely.
Hand hygiene. I'm curious to delve into that. In terms of measuring that, I mean, you don't literally get to see each and every possible opportunity for somebody to wash or not wash their hands. So I suppose, what can you tell, share an example, a little more detail of how you really measure that on an ongoing basis in a way it's not super time intensive or cost intensive?
Oh, that's a great question. And I get asked this a lot. And what we have in one of our London clients, who, by the way, just won an award from the UK Infection Prevention and Control Conference for their hand hygiene improvement, you earn the right to reduce the frequency of measurement. So let me tell you about that. So they measured daily, posted weekly, and they started getting these trained observations. So this was manual observation, which always has a host of measurement system issues such as bias, and nurses thinking nurses are perfect and doctors thinking doctors are perfect. But lo and behold, we go through some significant training of observers to get truth. And that's the key point, is to get truth. And then, as you know, Mark, and you can talk to hundreds of people in healthcare, when you first walk onto a floor or in an OR, theater as we call them in the UK, it doesn't take you but seconds to be able to reproduce the number that their hand hygiene compliance chart shows on the wall. So you do it by manual observation from trained observations, but then there are some technologies. In fact, my team wrote the request for proposal to some of the world's leading technology companies to come up with some technology to measure hand hygiene. And it can be done. Do we need to do it? No. As my my boss and friend, the guy that recruited me to Healthcare Performance Partners, Dr. Dave Munch, they did it without any technology in Lutheran Exempla. This is absolutely public information. But they did measure, and they managed to that measure. They called just-in-time coaching, and they made it easier and easier. Like you said, they found the barriers to people washing, and they took those barriers out, and they showed people that, we're serious. You tell us what your barriers are, we'll make it easy. But coming back around, it's very clear that managing to the measure is teamwork, not shall we say, writing the course to pass the exam. I'm glad you brought that up.
Right. Well, and just a quick aside for the listeners, Dave Munch, Dr. Munch was a previous guest of mine. You can go to leanblog.org/139, episode 139, where he was on before. So, the measurement, let's talk a little bit more about measurement and data, because, what I see and hear about in hospitals all the time is just the lack of data that would prove improvement, before and after data, in all sorts of varied settings. What are your perspectives on, and I'm trying to look for, maybe we won't properly diagnose it here, but thoughts around getting closer to a root cause about why that data is just often not available, why things aren't being measured, if that's so important?
Well, let's take, for instance, our scale in the bathroom in our homes or in our flats. How many people just hesitate, almost fear stepping on that scale, whether it's to lose weight or gain weight? Yeah. So I think, a lot of it is measurement initially can be very uncomfortable for people. And the nice thing about a safety culture, and maybe just a quick definition there, but high reliability organizations, those organizations that do it right the first time, that they're very used to putting measurement systems in and making it safe to say, this measure isn't what we want it to be. And so I think, again, it's really managing to the measure again says, we're going to start measuring. You're going to be a part of it, team. What measures do you think your customers care about? And that's the other nice thing about the CMS value-based purchasing. And this again, the program hitting most acute care hospitals this year is CMS gathered them together and said, what do patients really care about, those outcomes? But you go back and you say, let's be a part, let's have the front line. And the front line could be a surgeon in cardiothoracic surgery, or a nurse or a housekeeper, or I myself. It's the people doing the work, adding the value to the patient or the customer, getting them together and helping them design the measurement system together. Because if people know what leadership knows, and leadership knows what the people know on the front line, then they'll probably feel like each other feels, and then they'll probably do like each other would do. But it's that first part about you have to communicate what your vision and mission is before you start jumping into measurement systems that may very well be worthless. So first off, make measurement easy, make measurement the right thing to do, and reinforce people who report. The Consumer Reports organization just in August published for the first time its safety rating, and yet out of 4,900 acute care hospitals in America, only 1,800 had supplied data. What does that tell us, Mark?
Right. Well, and there's a lot of great things you touched on there. One, I think connecting measurement and work in general to purpose is really important. But then when we talk about involving people and helping develop their own measures, and resistance to change, quote unquote, resistance to change is something Joe and I wrote about a lot in Healthcare Kaizen. That most resistance to change, I think, should really be described as resistance to someone else forcing an idea upon you. And it's a natural reaction of why people kind of cringe at that. And I assume performance measures could be the same way. If someone has a measure forced on them that they don't understand or don't believe in, that's not really going to create much engagement. I'm curious to hear more of your thoughts on that.
Well said. And maybe the best way as a story is we had great hand hygiene improvement happen in our cardiothoracic floor at a major client, and these same nurses and nurse managers and housekeepers and caterers all got involved, but yet They were really struggling in the peri-op processes, the ORs, and the director of the OR had not been a part of the creation of the training and the observation, and even the 5 moments in WHO don't necessarily translate directly for this person. So once they let him become a part of the measurement system creation, things started taking off. So again, there's an example of if you get people involved with saying, we know that we can save lives if we wash our hands. Let's know how well we're doing washing our hands. And once they got the team involved, engaged, and empowered, it really took off. Case in point.
One other thing I wanted to touch on a little bit was something you touched on in the book, and I started highlighting and marking in the book, and so I definitely want to talk to you about this. Is the idea, and I think we share a view on this, that it's really an unfair position to put patients into when we try to insist that they ask to inspect the healthcare that's being provided to them. Are people washing their hands? Have you sign the surgical site, et cetera, et cetera. Curious to hear, can you kind of elaborate on what you touched on in the book or the examples you use, how you describe that? And if you're making a headway in helping convince people that they shouldn't put the customer in that position.
You hit a hot button of mine. I was shocked when I joined the Joint Commission and I heard about this campaign to speak up. I literally thought they were kidding me.
Yeah.
And I said, you mean to tell me that you're putting the burden on the patient to speak up if the doctor entering your room did not wash her hands? I said, let me understand this. I said, that's kind of like I'm going into the Ritz-Carlton, not that I'm lucky to do that very often. It's more like the, without naming brands, it's the $20 a night hotel, which is where we usually stay. Dave Munch, Dr. Munch, often calls us the $20 a night club hotel. But say you go into the Ritz-Carlton, and how would you feel if the person who greets you by name, it's unbelievable what the Ritz-Carlton quality can be, but they greet you by name out on the lawn, and they said, Mr. Graban, welcome to the Ritz-Carlton. We know you'll enjoy your stay. But I tell you what, it's up to you, Mr. Graban, to make sure that the luggage I bring to your room is your luggage. How would you feel about the Ritz-Carlton quality? And even though I like your lug nut story a lot better, Mark, than my story, it's the same point. I said, we have got to put the responsibility for quality and reliability in the hands of the people in the process, not the customer. And when you confuse who's responsible for quality, it opens up Pandora's box. Nothing you want to do.
Well, amen. And yeah, my lug nut story, the comparison I draw is that, if you buy a new car or you get your tires rotated, there's not a big sign saying, hey, ask me if I've properly tightened all the lug nuts. Because if your wheel and tire go flying off while you're on the freeway, that could be a deadly situation for you or somebody else. So it's critically important. Airlines don't ask passengers to ask the pilot if they're following the checklist, on this flight or not. They've put, whether it's these organizations, they have created much better reliability by putting the pilots or mechanics in a far better position to be able to do high quality work, which is what everybody in healthcare really wants to be doing. They want to be able to do the right thing if we don't put too many systemic barriers and organizational barriers in their way.
Amen. And we were just talking with a client out in Colorado today, and they've launched what they call the crew resource management. We knew in United Airlines that to be cockpit resource management. But that clearly, again, puts responsibility not only on the captain, but on the other flight crew member that in incapacitation or even concern about that, it is very clear who's responsible at each part in time, and then the escalation. I wish I could see that in the surgical theaters more often. And I think the the best surgical teams do just that. They said, I'm the surgeon, but, I really value you as team members, and if you see something, I definitely want you to speak up.
Well, and that's a really important point, and I appreciate you sharing at least just a glimpse into your new book, utilizing the 3 M's of process improvement in healthcare, with the subtitle "A Roadmap to High Reliability Using Lean, Six Sigma, and Change Leadership." Rick, I'm sure we could talk about this and all these other topics for hours on end. Hopefully, we can do another podcast, and maybe we can pick another topic and dive into a little bit more detail. So thank you for joining us. And in wrapping up, if you've got a final thought, can you also share how people can reach you, where the book is available, things like that?
Thanks, Mark. I really enjoyed it. Anyone picking up the book, you don't even have to buy the book. Go on to the book's website, www.rpmexec.com. That's Richard Paul Morrow, Edward X-ray, Edward Charlie.com, and tell me your thoughts. Tell me about the problems you're having out there, whether it's healthcare or not healthcare. There's a companion book utilizing the 3 M's of process improvement for everyone else in the world. The publisher asked me to do a healthcare version, but go onto the website, www.rpmexec. Share your issues, share your ideas, and I'll try to be that little bee that pollinates the flowers. Give me your ideas and let me share those, and we'll continue the mission to improvement and high reliability that way, Mark. And thanks for this opportunity.
Well, thank you, Rick, and good luck with all the great important work that you're doing. It's great talking to you.
Likewise, Mark. Thanks a lot.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.